It's my distinct pleasure to introduce Stan Chetcuti, Director of the Cardiac Cath Lab and Director of Structural Heart Services at Michigan Medicine, also Co-Program Director of MICHIC, the Michigan Structural Heart Collaborative, who will be discussing revascularization and TAVR Part 1, and then we'll have a Part 2 from Dr. Hanson, who I'll introduce shortly. Dr. Chetcuti.
Raj and Hitinder know me very well. The one thing I'm really passionate about, apart from structural heart, is Liverpool Football Club. And if I was sitting there, my phone would be on because they start about 15 minutes. So put me on the podium and I can check what's happening, which is the most stressful thing that happens to me any day. Let me just. So here are my conflicts, and I want to illustrate these because conscious or subconsciously, I might be biased in some of my discussion. And I wanted to put some sort of goals into this discussion. This was given to me by Raj, and he said, these are the things I want you to talk about. Revascularization strategies with TAVR, discuss the data or lack thereof, how we think about which valve to put in the context of coronary vascular disease, and then coronary physiology and aortic stenosis. And I thought that the best thing we could do is I'm going to give you 2 case scenarios, ask questions, present some data, ask the same questions again. So remember about these cases and see if anything I said made you change your mind. So the first case is, these are 2 cases in the last month at the university structure program. 85-year-old female with severe AS with decreased exercise tolerance, NY class 2. There's her height and weight. Sometimes this is germane. STS score was 2.8, MNM 14.6. Had some instrumental risk. She failed the CAT score, frailty, and the recent CVA. So the heart team felt she was I'm not going to get into the details of the whole why TAVR, but felt she was high risk, ideal for TAVR, valve area 0.7, area index 0.36, dimension 6.21, mean gradient classic low, paradoxical low flow, low gradient AS, and a cardiac catheterization, which I'll show you, so the heavily calcified proximal RCA and amid stenosis. So before we go into cardiac catheterization, we believe a CT is critically important. So the workup involves a TAVR CT first, because the anatomy of the particular patient, the geometry of the sinuses, what valve can be put in, if it's even feasible, is critically important. So we don't access the vessels more than once if a decision is made afterwards to fix. So if you look at this case, you have a perimeter of 78, an area of 478.6. Coronary heights are all over 8. Sinus widths are over 30. So this patient is an ideal candidate for a 26 valve Edwards. It would be a 25 or 27 portico or a 29 core valve. So here, I don't know if it projects very well, but there is, this wasn't done by me. Originally, it was one of my colleagues. There's a heavily calcified proximal lesion. The hemodynamics damped. There's a mid lesion as well, you can see in the RCA. And the left system, thankfully, was unremarkable. She has neoclassic angina. So if you can go back to your slide, for those of you who had it, who would propose medical therapy, perform TAVR first and treat the CAD after the TAVR, send for SAVR and single vessel cabbage, intervene prior to TAVR, or intervene at the time of TAVR. I think when we get to like 20, we can just sort of see the answer. So maybe we can see what. So medical therapy for CAD and intervene prior to TAVR are the winners, neck and neck. Perform TAVR after first and then treat after CAD after TAVR. Intervene at the time of TAVR and send at least no one sending for cabbage and single vessel. Case number 2, a 57-year-old male with severe AS being considered for renal transplantation. A very sad situation. He, as you look at his past medical history, he has aortic stenosis, obviously, that's why we're here. His known CAD had a history of a CTO of his RCA treated in March. CKD, excuse me, CTO of his RCA on a cardiac catheterization. I'll show these films. He's in CKD stage 4, GFR 30, hypertension. He has bilateral above knee amputations, and in spite of this, his BMI is still 38. So it gives you an idea what his body habitus looks like. Type 2 diabetes, sleep apnea, and CPAP. Here's his CT parameters. I focus on the important things. You have an annulus area of 563 that would fit with a 29 Edwards or a 34 core valve. Perimeter is 85.7. Coronary heights look good. STJ is 23.5. So when we look at what valve choice we do with CAD, it's not just what we can do today, but also do we have the potential for a TAV and TAV? So here is the patients selectively engaging the circumflex. You can see you're filling the RCA. The LAD, again, has no significant disease and the circumflex is occluded. And again, same questions as we had before. And then I get to the meat of my discussion. Okay, so most of us would do medical therapy, perform TAVR first 10%, intervene prior to TAVR 10. So there's about a 10-10 revascularization. So just to remember, because we got back to these, it was 41-41 for the first question, 10-10, and 70, a vast majority with medical therapy. So in my mind, when we approach CAD in patients undergoing TAVR, there's 4 buckets. Medical therapy, which is kind of the questions I asked, PCI and stage TAVR, same setting PCI and TAVR, PCI after TAVR is per appropriate use criteria. And these are in my mind, going into this talk, what I felt were the pros and cons of PCI prior to TAVR. There's advantages. You have concomitant DAPT prior to TAVR. So these patients who may have Hades syndrome or combination of bleeding tendencies may bleed before you have your TAVR. Repeated vascular access, radial or non-radial. If many of us are using Sentinel or embolic protection devices, messing up the radial 1 or 2 weeks before you're going to do that procedure, less convenient, patient has to return twice. The benefits, you have free access to the coronaries. You may increase your hemodynamic stability at the time of your TAVR, especially if you have rapid long pacing runs or your other hemodynamic instability. Reduce contrast and radiation when compared with concomitant PCI and TAVR. Think of this last point and remember this, because this is very humbling to me. This is what I just jotted down, in my opinion, why I think there are benefits. Concomitant PCI and TAVR, disadvantages when I have 4 or 5 TAVRs in one day and I'm bouncing from room to room. If you add even 5 extra minutes to the case, it sets a domino effect in motion that kills me and kills the whole team. So it's a more lengthy procedure. There increased use of contrast in a single setting. This is very important. Maybe it shouldn't be to us, but it's the reality of what we live in. Hittinder would come back and ask me why we're doing this. There's a loss of reimbursement for PCI at the time of the TAVR. Increased use of radiation, or at least perceived increased use of radiation. Focus tends to be on getting the TAVR or the PCI, getting secondary focus. So like it becomes, whereas when I'm doing PCI, it's the most important thing of that time. The PCI is just an introduction to the TAVI, and you might not be doing the PCI with the same level of intensity you do when you're doing a dedicated PCI. And you need to fully focus to optimize the PCI at the same level as standalone. The benefits, free access to coronaries because you do it before the TAVR is implanted. TAVR, may increase procedural safety of the TAVR, avoid repeated vascular access, and improve resource utilization. So what is the scope of the problem? What is the incidence of CAD in the studies? These are registries and studies. If you look from the extreme risk, as we go into the lower risk patients and in registry and in real life data, the incidence of CAD can be as high as 81.8% and as low as 44.3%. And the impact of CAD after TAVR on a variety of meta-analysis and a variety of studies really doesn't make a big difference into the outcome of your TAVI, and with some caveats. The impact of CAD in prior PCI and TAVR patients, no CAD versus CAD, no significant difference. It doesn't really matter whether they have it or not. And even when you look at it by syntax score, it's only in the high syntax score does it seem to have an effect on your outcomes at 400 days, at 18 months post-intervention. If you make it even go syntax less than 9 or more than 9, there seems to be some percentage that there is paradoxically, in the lower ones, make no sense to me. The syntax index, 9% of death is against the complexity. So to me, again, but as Dr. Bates said, there was, and again, this is the evolution of the space. This is a 2016 consensus, an ACC Interventional Council. These are not guidelines. So for the pre-TAVR patient, for evaluation of coronary angiography, if you have significant CAD and it's proximal endocardium with or left main stenosis, if it's yes, consider PCI prior to or at the time of TAVR, if PCI is not prohibitive. So a lot of sort of give. And if there is no disease like we described, concerns of patient symptoms coming from CAD, consider PCI, no, reassess after TAVI per AUC, and if access to coronary will be limited by TAVI, consider a pre-TAVR PCI. If there's no CAD, obviously proceed to TAVI. And if you look at randomized clinical trials, the partner, TAVI, partner 3, evolute low risk, 12%, so between 4 and 22% across these studies had concomitant revascularization. TAVR plus PCI versus TAVR plus CABG in partner 3, 58 versus 32. So again, not very robust data. And if you look at benefits from revascularization over a plethora of studies, the big diamond on the bottom is right in the middle. And I am not a meta-analysis expert like Hitinder here, but this to me was very, very eye-opening. There are variety of revascularization strategies, and I'm not going to belabor this too long. If you look at what we saw in TAVI, there is no revascularization versus no. So if there's no need for revascularization, revascularization with TAVI or SAVR, the numbers kind of overlap significantly. And if I had to conclude this, the proportion of patients deemed to need surgical revascularization for CAD was low in the evolute low risk, but mostly had SAVR. Patients received concomitant CABG, but selective PCI was performed in 50% of TAVR. So it was not complete revascularization, we did it percutaneous. The strategy of TAVR with selective PCI provided similar outcomes to the strategy of SAVR with CABG with complete revascularization in low-risk patients. So, and then busy slide, and this is the evolution from 2017 to the more recent 2020 guidelines, and then this 2021 guidelines, what to do in patients undergoing valve intervention, low risk of CAD. You can do coronary CT angio and coronary angiography. If you have left main prior to PCI or TAVI, complex bifurcation left main, syntax score over 33, consider sending the patient to SAVR. And basically very similar pathways for the valve surgery arms. And this has gone so far now as to some of our colleagues, we all very friendly with Adam Greenbaum. Adam in public forum now says, I don't even do an angiogram prior to TAVI. I go straight to TAVI. And this is where it gets, there's a lot of data, but the data is very, very humbling. So Dr. Kumar and his group, analysis from a pooled multi-center registry, basically shows that there is no difference if you do PCI before, peri, post. And then this group from Oregon, Faraz Zar, many of us remember, trained at Beaumont, I think, for a while. And the activation group, which I'll come back to, shows that paradoxically, the patients who got TAVI pre-procedure had a higher risk of bleeding complications at the time of their TAVI or peri-TAVI procedure. And then Tran and LaRue basically showed the one group that showed that there is some benefit of pre-procedure TAVI is if your syntax score was 12 and higher, the 1-year MACE was higher in patients who did not have complete revascularization. That's the one study. Otherwise, and then the even more humbling for me is, you remember my argument that if you do it at the same time, you have higher risk of nephropathy and radiation. The ones who actually got concomitant PCI at the time of TAVR had lower contrast nephropathy. Or at least nephropathy. It obviously wasn't contrast because there was one contrast, but maybe fixing the aortic valve disease gave you a better outcome as far as renal perfusion. So I'm going to give a shout out. I know two of our, Ivan, you guys are doing this at Bowman. I know our Henry Ford colleagues are doing this. The complete group that did the complete MI revascularization study are doing something very, very similar. It's David Wood from Vancouver running the show. It's basically a strategy of complete revascularization 1 to 45 days post-TAVI and versus medical therapy. Now, there's always some subtle hidden politics in this. We all know that it's more difficult to do PCI through a cage of a core valve. So the fact that they do this 1 to 45 days post gives benefit. It is an Edwards-driven type of study because it's easier to do PCI post-Edwards. But it is a very good study in that you see what the strategy is. Here are the steps of the study. And for those of you working in the centers, I said, please, it would be very helpful if you enroll because this is a question that we need to answer. And just like complete MI gave us a significant surprise in the way we practice now, this may be very, very different because as we've seen so far, the data is quite humbling. Coronary access after TAVI is not easy. One valve clearly stands above in the perception of easiness. The Edwards valve is lower. It doesn't occlude the coronary. It doesn't stand before the coronaries. There's no frame across from it. But it also depends at this point in time with current technology, the question of commissure alignment, which we don't have with one valve. And if you look at some of the data, and I'll show this, sort of, let me go back here. Outcomes of cannulation in Barbunti and Certavi, it was deemed to be easy in most of our patients, difficult in a small number. And if you look at left main cannulation after TAVR versus RCA, most of this is a very teachable technique that we have to do better in. And I've put the onus on us in interventionists who do TAVR, excuse me, I keep going to the European word, and to industry who has siloed the structural specialty into a structural field team that has not really shared techniques and best practices to the population at large. So for those of us who live in this space, this comes natural. I know what the issues are with coronary access with a core valve. If you can see, the sonotubular junction dimensions are important. When we talk about waist, the waist is this area here where it gets to be skinnier. We know the skirt is 40 millimeters high, so nothing can go through here. And so anatomically, the leaflet length is also important, not just for the acute implantation, but when we put a valve inside it. The sentence of Valsalva width is critically important, and the coronary heights. So there's device and procedural issues. Commissurial tab orientation is important. This phenomena, which the C tab, it looks like there's a C on fluoroscopy, will help you understand if there is commissurial alignment. The sealing skirt and the valve implant. As we've gone to a higher drive to implant TAVI valves higher and higher and higher to decrease the risk of pacemaker, it has come at a price of not occluding, but making coronary access much more difficult. So the pre-CT planning is critically important so we can understand how deep the implant has to be. So there's a refinement in our implant technique too. And then the Navitor, for those of you who have not seen it yet, is on the market. It is kind of a mixture of Edwards and a Medtronic valve, and that it is intraannular, but has a frame. But these frames are much, much larger, dynamic, and much larger size, so it creates an easier access for coronaries. Coronary access after TAVI, we all remember the one nightmare case, but if you look at a number of studies now, it is, as I alluded to, a very teachable event. And it's embarrassing to say that the one paper I was in charge of, we had one of the lower rates. Just put things in perspective, this was 2015. We knew nothing about how to engage coronaries. This was in a pivotal study with core valve. We took, a bunch of us went into a room in Minneapolis airport, looked at all the studies and saw what people had done. From that initial event, we created best practices as to how to engage coronaries, and I'll defer to my colleague here afterwards. We'll probably go more into that. And then what's also important, we've realized now, not just with core valve, but with any valve, is the issue of coronary alignment. And how do we achieve that? There is a technique. If you look on the left with green, that's a favorable alignment. Those diamond cells are 10 French. So most of our 6 French or smaller sheet guys could go in. If it's unfavorable, no matter what you do, whatever technique you use, you're going to have problems because you have to navigate around it. And then you have to free wire, probably use guide extensions. And so there is a 4-step procedure. We're going in at 3 o'clock. I'm not going to belabor this too much and do all these maneuvers. And when we do these 4 maneuvers, we have found in the last iteration, we are able to achieve commissure alignment in 97% of our cases. And what's even much more reassuring that using these 4 techniques, I just came from a week in Japan, and they did the same thing in the Little Japan registry, and they have achieved commissure alignment in Japan at 97% of cases. So this is a technique that is reproducible across the world. Quick deviation from what we've talked so far is the assessment of hemodynamics of a lesion FFR at the time of pre-TAVR assessment or peri-TAVR assessment. This is a population of moderate to severe CAD with severe AS, 28 patients with 30 lesions. Combined coronary pressure and Doppler flow assessment, pre and post TAVR per data, and the outcome was DFR, IFR, flow resistance, including phasic analysis. And I'm not going to go to the depth of the paper, but the mechanistic take home is patients with severe aortic stenosis have a blunted hemodynamic response to adenosine. These patients are already hyperemic at rest because the aortic valve stenosis is like a second stenosis in series. They have an attenuated hyperemic systolic flow, bulk coronary stenosis, and the severe aortic stenosis, lower microvascular resistance, i.e. the microcirculation dilates to try and maintain flow. And accordingly, severe aortic stenosis can be considered a tandem lesion to a coronary stenosis. So FFR does not appear to be suitable, apart from the fact that giving adenosine to someone with severe AS, but does not seem to be suitable to assess coronary stenosis in patients with severe AS. Resting flow during diastole when the aortic valve is closed is less impacted by severe aortic stenosis. Accordingly, IFR may be preferable for coronary stenosis assessment in these patients. The activation study, which is the one that showed us that if you treated patients pre-TAVI, you had higher bleeding risk at the time of TAVI. Big group from Canada. Tiffany Patterson was the PI. This is the scope of the study. Scheduled for TAVI with CAD, greater than 70% angio, non-left main stenosis. Note, Canadian class symptomatology was less than 2, single vessel, randomized 1-to-1 to PCI versus no PCI. There was non-inferiority of the PCI arm to no PCI, again, so. And then the outcome of all-cause delirium hospitalization at 1 year. In the summary of the study, severe AS patients and CAD coexist. Mechanistic data suggests that in severe AS can be considered a tandem lesion, which we've said. So this is a second study confirming this. Resting physiology may be more accurate and optimized in the setting of severe AS. However, the benefits of revascularization by PCI in patients with severe single vessel AS and Canadian class symptomatology 2 or less are not currently supported in single vessel non-left main setting with low burden of angina. So going back to the first case, the lady who had the RCA, calcified stenosis, and the mid stenosis, how would you treat her with those data we just presented? So clearly, there's a big change from the 41-41. We're at 76 for medical therapy. Unfortunately, we fixed, and I'll show you what we did. I'm not going to belabor this too much. We wrote out IVUS guided, stent proximal and mid, and then we implanted a TAVR valve. In this case, we presented a 29 Evolut because of her, we felt was an ideal valve for her, and we feel comfortable engaging. If you, and let me just do this very quickly. We feel coronaries are wide open. If you look where the waist is, we're able to engage this RCA quite easily through this cage. So that's the C-tab I told you about. It looks like the one tab with lucency through it. There's the height of the skirt. And those 3 dots, 1, 2, 3, are the commissure markers, which in this case designate for us that we have appropriate commissure alignment. Second case, the gentleman with the above knee amputations and the CTO RCA, and not belabor this too much. So we decided to treat medically. Houston Edwards, sorry. Anyway, it's not playing. We had no regurgitation. We had good access to our coronaries. So in conclusion, in the absence of symptoms, pre-PCI TAVR should be really reserved for patients with lesions in proximal epicardic vessel if it's felt to make the TAVR procedure safer, or if it felt that subsequent PCI would be more difficult post-TAVR. Timing of pre is based on multi-frequent decision tree that includes repeated access, consist, and fluorodosis, and the importance of reimbursement issues. We eagerly await the conclusion of studies like complete TAVR, and its careful consideration of coronary anatomy, patient size, and valve durability should be important discussion points in determining TAVR valve choice at Heart Team Conference. Thank you.